This week on the BackTable podcast.
The biggest challenge, I think, is really those people who went through their training and didn't get a lot of experience and want to or need to, because of where they are, to get the experience to do stroke. And I think that's really probably one of our biggest challenges, because where are they going to get the hands-on training? Where are they going to get the experience? Through the stroke courses, we're able to provide the cognitive, and we're even able to provide some hands-on in the models and the simulators. And as those get better and better, it gets closer and closer to taking care of an actual patient. But it's really getting that experience, treating patients, getting the hands-on. And I think that's really where one of our biggest challenges is.
Welcome to the BackTable podcast, your source for all things endovascular or otherwise minimally invasive. You can find all previous episodes of the podcast on iTunes, Spotify, or BackTable.com. Subscribe to the podcast, leave us a review, or reach out to us on Twitter or email to let us know how we can make this a more valuable resource for the endovascular community.
First, a quick word from our sponsors. A decade ago, RapidAI harnessed AI to revolutionize stroke care. Now they are bringing that same innovation to aneurysm and pulmonary embolism. This AI-powered, clinically driven workflow platform enables care teams to accelerate triage and treatment decisions and improve operational efficiency to achieve better patient outcomes. RapidAI, where AI meets patient care. Now, back to the show.
Welcome, everybody, to the BackTable VI podcast. My name is Venu Vadlamudi. I'm an interventional and neurointerventional radiologist, and happy to welcome good friend, partner in a lot of things within SIR and others, Marty Radvany, who's down in Miami, Florida. And Marty, I'll let you introduce yourself a little bit, and then we'll jump into the topic of the day, which is in and around stroke.
Thanks, Venu, for the kind introduction. I am Marty Radvany. I'm also a dual-trained neuro and body IR, and I have been really focusing on trying to push the cause for IRs in stroke. And it's something that's kind of a passion of mine, and I believe very strongly. And I think we'll get to how things are going as we go through the podcast.
Likewise, as Marty said, passion for stroke and stroke care, access to care, a lot of things we can jump into in this podcast. So I think to start off the conversation, maybe we'll take a look at the sort of state of affairs in the middle of 2022 in regard to stroke and stroke in general, for those who may be less familiar as far as endovascular therapies and where things stand. And then we can, maybe morph into, where do interventional radiologists fit into that equation? Marty, you have some thoughts as far as, where we are in 2022?
Well, I think we made a lot of progress since we really kickstarted things, I would say, back in 2015, 2016 timeframe. That's when we did the reboot on the stroke course with SIR. The neuroservice line kind of got really well established. And I think we've had quite a few initiatives in that time that are finally starting to come to fruition. And it's kind of gratifying to look back over the last few years and realize that we have been making some progress. I think one of the big things is just as far as training for the residents and fellows, that has cerebral angiography is once again part of the required training for IRs, which I think that's just bread and butter. When I went through training, it was part of my training. And I think it's important, and I'm happy to see that it's now again a requirement, because as you and I have seen, when you leave the ivory towers and get out to the community, who gets asked to do a lot of cerebral angiography? And it's the IRs.
Yeah, exactly right. I think, in this last several years, specifically 2015 onwards, we know that this big paradigm change in terms of stroke care and endovascular therapies, and, it's really become, of course, a standard of care in a lot of cases, and certainly a lot of data coming, rapid fire, showing the benefit of stroke thrombectomy in, varying situations. We're starting to see data around low aspects or low NIH, going for more distal lesions. And so all the more reason, having, a cadre of folks who can provide that care, good educational opportunities for them is very important. So certainly been a pleasure to work with you on a lot of these, different aspects and projects. And at the same time, as you said, really good to see SIR focusing the energy and effort toward, neurointervention and stroke care, so that the current generation of folks who are in practice, and then of course future generations can, really have both the opportunity and even from formal education, kind of bringing some of that back into the training paradigm. I've had, an interesting perspective over the last several months, been doing some locums coverage, really kind of all throughout the country, and have been finding that there are a lot of practices out there that, really are reliant on interventional radiologists to provide stroke care. And there's really, certainly areas that have, a lot of need, and the geography doesn't always, allow for patients to find these, larger tertiary centers and, have formal neurointerventionalists on 24/7. Many practices may have some access, or, one person out of a few, and that's great. But, the reality is that in order to provide stroke care to as many people as possible, I think it does require interventional radiologists to be part of that conversation. Along those lines, Marty, and certainly you've been at this from the stroke and neurointerventional standpoint and with SIR even longer than me. Can you kind of give us maybe a little bit of, if you will, a historical perspective, on going back to things like the Clots Course, and then where you see things today? Let's say most recently, we just finished up the 2022 SIR meeting in Boston, including a stroke course. So what are your thoughts there?
It was interesting. As I was preparing for this year's annual meeting and the stroke course, I was looking back through what had actually happened with SIR and, so forth. And looking back at the program, it was interesting to me to see that back in 2000, we had big names, Jacques Dion, among others, who were speaking at what was at that time Skiver, but the SIR annual meeting. And to see how things are moving forward over time, it's kind of ebbing and flowing, so to speak. The Clots Course came into fruition, and it was a great course. I did not have the good fortune of attending it. I heard it was brutal, from the sense that you got locked in a hotel room for, I can't remember, it was 3 or 5 days, and it was very intense. Since then, our tools have improved. As I said, I was able to reinvigorate a stroke training course for interventional radiologists with Jeff Carpenter. And that was back in, I think the first course was in 2016. And we had started that going. And at that time, we were very pleasantly surprised. I think we had about 70 participants in the course, which was a very pleasant surprise that there were that many IRs practicing. And we really maintained that kind of a attendance throughout the courses that we had been running. And then you joined the team, and we've continued having the stroke course. So we even had our brief foray pre-COVID into a more in-depth course at the ACR Learning Center, which, was a 2-day course. And we had about 65, 70 people coming to that course from the US and Canada. And there were, IRs, neuro-IRs, even diagnostic radiologists who were there to learn about stroke imaging. And then those interventionalists for more in-depth discussions about the actual interventional procedures at that time. COVID came along, kind of slowed everybody down for a couple of years, and we all went to our web meetings, and we actually were able to maintain some sort of a curriculum for IRs with the assistance of SIR. We had the courses that continued then, and we had the quarterly stroke case conference, which really, I think, helped bring people together through COVID when we really weren't meeting face to face. And then, just recently, you and I were up in Boston. We were doing the stroke course again. It was nice seeing everybody in person. And I think we're coming around. I think that offering is going to continue to expand. And I know that we've discussed growing it a little bit, as things move forward.
What would you like to see, for interventional radiologists in and around stroke education opportunities? What would be your dream state?
Well, it would be great to be able to grow the stroke course. And as you well know, because we've been working on this for a while, it's we've been doing it in conjunction with the annual meeting. And I think eventually to break it away, just like several of the other courses, the Y90 course, the Learn course, if we could develop to the point where it's a freestanding course, I think that would be amazing. And I think to incorporate imaging, because we know that, imaging is a very important part of it, just from the diagnostic standpoint for even diagnostic radiologists, and then for interventionalists, expand upon the training and teaching that we can offer to them. And I think what would be fantastic if we are able to get to the point where we have more hands-on work that's supported by industry, and we can do these more advanced workshops using flow models as well as the simulators, and then even proctoring remotely using several of the systems that are, I want to be kind of agnostic there, but there are several these remote proctoring platforms that are available. And if it could grow to the point where, you can phone a friend. I mean, right now, when you train someplace, when you leave and you have questions, especially during the first couple of years, you're calling back to the mothership all the time asking, okay, what do I do with this? And to be able to create an organized group of people and to offer kind of that ability to phone a friend for interventionalists who are having a challenging case, I think that would kind of really be the pie in the sky.
Great. And I think, hopefully things will continue to progress toward that goal of potentially having a separate stroke education course and, being able to offer more educational opportunities, including, hands-on and potentially things like remote or teleproctoring and advice, phone a friend, as you called it. To kind of a little bit change gears here, wanted to get your thoughts on the recent paper published in JVIR, looking at stroke outcomes in centers that had interventional and neurointerventional radiologists. Kind of your thoughts on that. What are potential implications?
I guess with regards to the article that you mentioned in JVIR, I think it kind of reaffirms what many of us know. I mean, your experience as well, traveling around the country doing locums. There are a lot of IRs out there doing good work. The invited editorial pointed out some specific things and certain limitations of the study, which almost any study is going to have limitations of one sort or another. Everybody's always going to be discussing who should be doing what. And, as interventionalists, we have seen this so many times. I mean, rewind, I'm going back a little further before my beginning into IR. But if you go back to coronary interventions, radiology was involved there and then kind of faded away from that. Then we had the whole thing in the late 90s, early 2000s with vascular surgery. Fast forward now, it's in the neuro world. And, interventionalists have been at the forefront, from the radiology background, have been at the forefront of these endovascular interventions for a long, long time. And, they have the experience, they have the training, and clearly each of these different vascular territories have its own specifics, and you need to be trained in those areas. But the fact is, IRs are out there doing stroke. They're doing a large percentage of it. We think potentially as much as 20% of the acute ischemic stroke work is being performed by interventional radiologists in the United States without fellowship training in neurointerventional radiology. And they're doing a good job. I think, I'm going to go off on the side here, but just the whole training pathway. We've seen that there's been discussion that started several years ago about alternate training pathways for radiologists that would make training, as far as the duration of the training, commensurate with other specialties such as neurosurgery and neurology. And there's been a lot of discussion of an alternate training pathway for IRs, those who have either completed an IR residency or an IR fellowship. And if during that time period, they can acquire the clinical background, the 6 months of clinical neurology, neurosurgery, neurointensive care that's really required to take care of these patients, and then also have enough of, from the imaging side, 6 months of diagnostic neuroradiology during the residency period, that then potentially they could go directly into neurointerventional training without the need for doing a year or two of diagnostic neuroradiology. And so I think that discussion has already happened. I know there are programs there that have already started adopting this paradigm. And I think that's fantastic for radiology, that now there's a second pathway for radiologists to go into this area. But what's even more important about that is that interventional radiology fellows and IR residents are starting to get this experience. And there are programs where they're graduating and having performed 30 or more cases, which I think is amazing. I mean, I remember when I was doing my fellowship, we used to do a lot of carotid angiography. and even carotid stenting early on. And it was just a fantastic experience. And now that, the people in training, now the fellows in training and residents are getting this experience again, I think it's exactly what needs to be happening.
Yeah, that's great. And, I think my takeaway from the paper, and full disclosure, I was one of the co-authors, but exactly, in the intent, the background, behind the idea of the paper was to really kind of put it out there, what we felt was probably happening, as you alluded to, that IRs are out there. We certainly, you and I and others, have also looked at that and asked that question, trying to get an understanding of how many interventional radiologists are involved in stroke care throughout the country. And by some estimations, perhaps around 20%. And to follow up on that, the number of interventionalists doing it, but also what's their outcomes? What are the data and quality? And this at least gave some sampling of that to get some idea of what's going on out there. Of course, to your point about the commentary article that came forth, and of course any paper, as you said, will have limitations, but I think it was important to at least get some data out there, something to showcase that interventional radiologists are involved in stroke care, certainly at a minimum at centers that have both a neurointerventionalist and a peripheral or body interventionalist. They can provide good outcomes and good quality.
Yeah, well, my current practice, when I came down here to Miami, the group I'm currently working with, we have 3 neurointerventionalists now, and we have actually 2 body IRs who help cover stroke call. And I have had the opportunity to watch them perform procedures, and these guys are great. I mean, they do a really solid job. They can really perform some complex cases to include tandem occlusions and have great outcomes. And this is, me coming as an outsider into this group and being like, here's something I've been talking about. And now I'm actually putting my money where my mouth is. I'm working with people who are doing this. And it's fantastic to see people doing a great job and great patient outcomes.
Absolutely. And I think that, as I mentioned in my more recent experiences, seeing different practices, and there are a lot of these practices that maybe are mixed, neurointerventional and interventional radiologists, or even some that I've seen that are only interventional radiologists, again, providing stroke care and especially access to care. And again, with really solid data, quality, and tracking and the outcomes, I think that's ultimately in the realm of stroke and certainly other diseases and interventions. That's really critical. So it's really good to see that, to your point, sort of the practices that are out there, are reflective of what we believe is happening. To shift gears a little bit, going along the lines of both this recent paper, but also a bit back to kind of education and opportunities, what do you think are current sort of barriers to interventional radiologists, either starting to get involved in stroke care if they're not already involved, or future trainees being involved in stroke care? Where do you think those kind of barriers or obstacles lie?
Well, I think there's really 3 groups of people when we talk about this. As you kind of alluded to, we have our trainees. There are some who are at those sites where they have the opportunity to scrub in neurovascular procedures during their training. And I think it's fantastic. I think more and more programs are starting to look at what the options are, opportunities are for being able to do this. And that's great. Then we have I'm going to go from the easiest to the more difficult. Then we have those practitioners who have been practicing, and we've run into those regularly when you and I have done the stroke course together. And there are some people with a lot of experience, and, they're kind of getting their 8 hours of CME. And, we have some great lecturers that we've been able to line up and just really get them the updates on what's the latest, greatest going on, like things we discussed this year with MEVO and posterior circulation strokes. And, we had some fantastic presentations from the people who are from our faculty. The biggest challenge, I think, is really those people who went through their training and didn't get a lot of experience and want to or need to, because of where they are, to get the experience to do stroke. And I think that's really probably one of our biggest groups to get the challenges, because where are they going to get the hands-on training? Where are they going to get the experience? Through the stroke courses, we're able to provide the cognitive, and we're even able to provide some hands-on in the models and the simulators. And as those get better and better, it gets closer and closer to taking care of an actual patient. But it's really getting that experience, treating patients, getting the hands-on. And I think that's really where one of our biggest challenges is. And Perhaps proctoring, teleproctoring may help alleviate some of those challenges. It's not going to fix everything, as we know. One of the big areas really is industry support. And that's one of the challenges, as you know, that we've faced for a really long time. And it's how do we manage to get our faculty members trained? And I know this is an area of consternation for many. We have seen it come and go.
Something you mentioned a couple of times, including in this sort of last line of questioning, and I know you have interest in, which is use of simulation and simulators. Can you tell us kind of where you think things are and where they might be heading?
I think there is simulator technology is something that I've been very interested in since the beginning. Seeing the first simulators where you could push a catheter and a wire, and on the screen you were actually performing a endovascular procedure was something that was very intriguing. And over the last 20 years, the simulators have really improved significantly, even to the point where you're starting to get some of the tactile feedback when you're performing procedures. When you have a patient, let's say, with not the straightest forward vascular anatomy, there may be an aneurysm hiding in there, plus a type 3 arch. And when you're trying to push and reform these catheters, it's amazing the haptics, the tactile feedback that is now possible when you're doing this. What would be fantastic is if we could finally one day get to the point where it's as realistic as training for flight simulation. If you use that paradigm, you look at, when pilots get in a flight simulator, it's that good that it can take the place of actually having been up in an airplane. If we can get to that point with simulation in medicine in general, for interventional procedures specifically, that would be a huge step forward. 25 years ago, when I was in the Army and I had residents, we were able to have an animal lab. And I actually took all my residents to the lab before I ever let them touch a patient. And we would spend all day. I would spend all day with 3 or 4 residents, and we would do 3 or 4 workshops. There were like 10 or 12 residents every year. And we did everything. We put filters in, we took them out. We stented everything. We put embolics of every flavor that we had available. We did all of that stuff. And if we could transition that and, move that over to the point where we're using simulators to do all of that before they even start treating patients, that would be amazing to get to that point.
Yeah, I agree. I did have, access and use of simulators during my training, fellowships in particular. And, even to look back, that's more than 10 years ago compared to now, the advancements have been really tremendous. I know this year at the stroke course, we did have simulators there, and just to see those cases and kind of look at the haptics, the latest versions of things, has really shown a lot of progress. And it does make sense to your point about looking at other industries like pilots. Use of simulators clearly has value. There's a lot of data around it. And, looking across the pond, if you will, in Europe, I know that, and you and I, we've talked about other models that incorporate use of simulators in part of their training. So I think there's really a lot of potential there. Again, maybe not just specifically in stroke, just really across the interventional spectrum, but certainly with stroke in particular, there's a lot of potential there to be able to do simulator cases, or even maybe as an adjunct to your actual daily clinical practice.
Yeah, I think we're going to get to that point where, we will be able to take the CT angiogram, the MR angiogram, or, even if it's not a vascular procedure, the imaging, patient-specific imaging, feed it into the simulator, and then you can actually practice on your patient before you ever perform a procedure. This isn't always possible for emergent cases like stroke cases, but let's say you had a hard time, a very challenging time doing the case. Well, maybe you have a little time in the background and you go back to your tool set and go, okay, what could I have done differently? What can I try next time? I tried this catheter, it didn't work so well. Let me try a different catheter. And I think as the simulators grow in power and we're able to do things like that even faster as far as bringing patient-specific anatomy or imaging into the system, we're going to be able to try a lot of things very quickly. Even something as small as by the time they're getting your patient set up, if the imaging data could move over to the simulator, you could figure out, okay, which catheter do I need to use to get up into this terrible looking arch? something as simple as that.
Yeah, I agree. In fact, I did a stroke case, last night, a 97-year-old patient, of course, type 3 arch, carotid loops, all of those sort of aspects. And it was a tough clot to deal with. And this morning, as I'm rounding, dictating the case, et cetera, I exactly thought that it takes, of course, time and cases and experience to be able to tackle that kind of a case. But, I kind of thought that what a shame in a certain sense that people don't have the ability to go through 20, 30, 50 simulator cases and get that kind of a tortuous, difficult, challenging anatomy type of case as part of a simulator kind of session to be able to see which tools they need. How do you push? What feels good? What doesn't feel good? That sort of thing. So I kind of look at it even in kind of ongoing practice and doing cases, that would be really nice, even if there's a portable version of a simulator, to be able to go back and say, here's what went well, here's what I might be doing differently the next time around. So I think there's, hopefully some advancements that can come there.
Well, imagine taking that case that you did last night, the DICOM image set, and then we have a course, as part of one of the courses, you feed that data into there, and then one of the trainees or somebody who's attending the course gets to spend an hour with you one-on-one fighting through that case, but it's in a safe environment and just trying all sorts of things. I think that experience would have a lot of value to it, to be able to do that. Somebody who's less experienced working basically with a mentor, or a faculty member in a course setting where you have an hour and a half, maybe even longer.
Yeah, absolutely. And I think that to that point, as far as training opportunities, use of simulators, flow models as well, being able to do that in that kind of a setting, I would love to have you do that case and I learn and see, well, what you would have done differently. And, what did you do that I also tried, that sort of thing. Because in a certain sense, it doesn't matter how many you've already done. You're always learning, you're always iterating and proving, hopefully, that, you can do those cases again as efficiently, as safely, as effectively as possible to ultimately get good patient outcomes. So I agree. I think it would be great, to be able to take those kind of cases, import them into a simulator and spend time, re-reviewing it, working with a mentor, phoning a friend, whatever it might be, to hopefully extract as much information, knowledge, hands-on type of experience with those kind of cases so that you're that much better prepared for the next one.
Yeah. I mean, imagine doing the case with just aspiration, try a couple different aspiration catheters. Then, okay, I'm going to try it with this case with the stent retriever. And, how does this go differently? Or even just the system that you use to get up there. What's going to be your guiding catheter? What's going to be your internal catheter that you use to select off the arch? There are a lot of different variables there. And, we all have our go-tos. There are certain cases we do, and we just tell the techs, especially in the middle of the night, just go with my standard setup, and they put it all together. And the standard setup works most of the time. But every now and then you get in there and you realize, yeah, that wasn't such a great idea. And now you're switching out things and trying to figure out what would have worked better. And if you had the ability to go back and try it again some other different way, or as we talked about earlier, in a course setting, have one of the other faculty do the case and go, okay, let's see how this person does it.
Yeah, absolutely. And for me, going to courses or even doing the phone a friend, what would you try? Have you tried this? Did you think of that? That's one of the biggest values. I think back and I sort of tell this story to a lot of different people because it just was kind of a very simple but extremely helpful thing I learned was from Jeff Carpenter, I think Dave Sachs, a few others, but basically people who I knew had a lot of experience, had tried a lot of things, suggested using a VTech catheter. It's a diagnostic catheter. It's just a slightly different shape than I'd used before. And I heard that from a few different people and I said, sure, let me try that. And that has been one of the biggest positive changes for me in terms of doing stroke cases. It's a simple change in a sense. I always envy when I don't have it around, but at the same time, I realized that helped me in a tremendous way. And it was probably the cheapest tip I've ever gotten in a sense.
Yeah, no, I mean, and again, as we talked about earlier, I'm happy we're starting to meet in person again because those hallway conversations that you have are fantastic. I mean, it's amazing the amount of things I've learned just sitting around chatting with people. It's like, I need to try that when I get back to my lab. it'd be even better if I could try it in a simulator first.
That's right. Yeah. Because there are so many tools and products out there, and you may not have access to all of them. And it would be, really nice between simulators and flow models to try different tools, different setups, different catheters, shapes, et cetera. And then see, maybe there's something that is better for the setup you'd like. Maybe it reaffirms that, your, if you will, standard or your go-to, hey, that works pretty well. I think that's, kind of another nice advantage of using some of these other technologies.
Well, and I think just doing cerebrovascular cases in general, switching from a femoral approach, which many of us grew up with, to a radial approach. I mean, there's a lot of advantages, I will say, for stroke. I still do a lot of cases from the femoral approach, but there are other cases that I've started doing more from a radial approach. Recently worked with one of the body IRs who got consulted on a epistaxis case. We went from a radial approach.
Over these last few years, you mentioned radial access, for example, but what are some of the things that you've seen, that you've tried, that you've changed in your stroke practice?
From the equipment standpoint, I've tried some of the new catheters and things that have come out, and I think that there's a place for some of them. I have to admit, I'm still waiting for that next quantum leap. Every now and then, how that is, you get your hands on a new piece of equipment, you're like, wow, where has this been all my career? In the stroke world, there are catheters that have been improving. We have catheters with beveled designs on them to help ideally increase trackability and aspiration ability. We've had other catheters that are very soft and easy, in theory, easier to advance than the previous generation of catheters. I think things are evolving. I will say that as we've started doing the medium vessel occlusions, my techniques have changed. Very early on, I did a lot of stent retriever thrombectomies. I will say that as I'm moving more distally in the M2s, the P2s, even the A2s, I've started using a lot more aspiration and a lot less stent retriever. And that may change again when we have new designs coming out in the stent retrievers. I mean, look at Europe. They always get the new toys before we do. But there are some interesting stent retriever designs that are coming out, and hopefully we'll have those available here in the United States to treat those clots that are recalcitrant. We've run into those where you try the aspiration, didn't work. Try the stent retriever, didn't work. And then you're kind of just sitting there, okay, now what do I do? And tools keep changing. We've all tried, I'd say we all, but many of us have tried, even the dual stent retriever technique. I haven't done it very often, but it makes me real nervous. It's just because it's a lot of hardware that you're putting in these very small vessels that are floating in fluid. But we keep pushing the edge because ultimately, what are we trying to do? We're trying to help our patients. And we push harder and harder because we have come to realize that the early trials, it's funny to say early because they were only, 7 years ago. And look how far we've come. But we're trying to do more and more for our patients because we're realizing that, okay, M1 was a good place to begin. The carotids were a good place to begin, as was the basilar artery, but now we're moving more distally. And so new tools are coming out. We're kind of trying things that in the smaller vessels, the things that may not have worked well initially in the larger vessels are actually maybe a better idea. And I think it's a game in progress. As I said, for me, I've started using more aspiration as I go more distally. What's your experience been?
Yeah, likewise. It is interesting, to your point, to think that, it was 2015, International Stroke Conference was in Nashville that year. And it was just 2 years after all of the quote unquote negative stroke trials. And again, all of it is less than a decade, a big paradigm shift from supposedly intervention doesn't help to, wow, intervention is definitely helpful, standard of care, and then pushing the envelope. So yeah, in your experience, and mine has been similar, pushing the envelope in terms of going after more distal lesions, medium and distal targets. I have likewise moved more towards primary aspiration for these targets, and I've had good success with that over stent retrievers, at least in my personal experience. Definitely pushing the envelope in terms of going after those with maybe a larger core infarct or some of these, low NIH patients that, we don't quite have all of the data as yet, but seems like things are moving in a direction that these patients will still derive benefit. One of the big concepts that for me has changed in terms of how I think or look at cases is kind of this concept in and around rank and shift. When you look at the trials, as we know, they looked for 90-day outcomes of 0 to 2 in most of the trials as being defined as a good outcome. But, this concept of, well, what if you can take somebody from a otherwise kind of terrible natural history of maybe a modified ranking of 5 or 6 and shift them? Maybe a 3 is not so bad after all. And so that's kind of been another way that I think I've shifted the way I sort of approach, stroke cases and a willingness to try. I don't know if that's anything that you've experienced as well.
Yeah, I think my group, the other interventionists I work with, we have started going a little bit more. And what I kind of try and make clear to everybody is we are happy to try and help our patients. But I think it's important to remember, and I hate coming back to this, but it's outside the guidelines. And that's one of the real challenges. The protocols are just being put in place right now to do these trials, to figure out, should we be doing these things? Really, what is good? We think that we're doing the right thing for our patients. That's why we do it. At 2:00 in the morning, we're not getting up just to come in and do a case, and have a good time. We're coming in because we think we can really help our patients. At the same time, it's important for people to understand that this is currently outside the guidelines, but, we're pushing the envelope because we want to help our patients. We want to try and make them better. I think that's an important thing to discuss, because the basic guidelines, those have been around for a while. We know what they are and we employ them routinely. But as we push more and more, we have to be judicious about when we do it. And I think it's important also to have important discussions with not just the other caregivers, but more importantly, the families. We have our other healthcare providers, and it's like, can you guys do that? And it's like, well, sure we can. It's not a question of can I, it's should I. And that's really one of those things in medicine that we always have to balance is this really in the best interests of our patients? I mean, the early data suggests that it is, and that's why we do that. And hopefully when these studies come out, we won't have results like IMS-3.
Yeah, I think that's a very good point about guidelines and standard of care, if you will, straightforward type of cases. They present in 6 hours, they have an MCA occlusion. That's standard of care. If there's no family present, if the patient can't consent, we move forward because, again, that's standard of care. But I think a good point about discussing, with the team and especially the patient and the family, at least currently out of the standard of care type of cases, what are the risks and benefits, but also, in a sense, tailoring it to the patient. I had a young patient several months back who had an isolated P2 occlusion and really kind of just a inferior quadrigenopia, but that visual deficit, was certainly something that was significant for her. It definitely would have meant the difference of, her daily life, driving, et cetera. And she worked in a field where she needed that vision, wasn't going to be acceptable. And so being able to have that discussion and, the case went well. And to your point, I mean, I can go in there and I can get the clot out. I feel pretty confident of that. Question is, should you do it? And, in that case, we had that conversation and moved forward. But I think that's always important to bear in mind is that as we potentially are pushing the current envelope and maybe a few years from now, it will no longer be the envelope. It's well within guidelines. But I think as we do that, we should be mindful and have those conversations and just be honest that, look, some things are not per se standard of care, but we think there's a benefit. And what would you like to do? How would you like to proceed? I think that's a good way of looking at it. Wanted to shift gears and think about going back to sort of the trainee side of things. You've mentioned cerebral angiography, for example, has come back into the fold as far as expectations within interventional radiology training. But what other things do you see or know about or kind of anticipate as far as for those in training? What things should they be thinking about or looking out for?
In IR in general, it's become much more of a clinical specialty. And I think the emphasis has changed there. And currently where I am, we have residents in the program and they'll ask me, so, even med students, interns, rotating interns, like, so what things should I focus on? And I almost, it's almost a cliche and I want to go everything, but it's really focus on everything clinical. You're going to get plenty of radiology training. You're going to get plenty of training doing procedures. But I think, for radiologists, I think one of the important areas is to get, especially for the young trainees, get the clinical training that you can, the actual time in the ICUs, the time in the floor, as painful as it may seem. If you really want to be an interventionalist, you have to know how to take care of your patients as well. One of the more important aspects, really for the young people going through training, is get as much of that as you can, because once you get out of training, it's kind of hard to go back. I mean, in my case, I was very fortunate. I went back 10 years later and did my neuro training 10 years after I finished my body IR fellowship. And it was like a sabbatical for me. It was actually a fun experience. I went from being the chief of the IR service at a level 1 trauma center to I'm just the fellow now. But most people don't get that opportunity to just stop what they're doing and go back and train for a year and get to completely shift gears. So that's one of the things I always tell the trainees is get as much experience as you can. If you're on surgery, go to the OR, see what's going on, see how the patients are being managed, learn as much as you can, because once you get into the radiology portion of it, you're going to see enough images. You're going to, you're going to go through your rotations. You're going to do that. When you're on your interventional rotations, you're going to get your interventional experience while you're there. But it's those other things that are at the time may not seem as important that really, I think, become much more important once you finish training, you get out and you start practicing.
Yeah, I agree. And really good advice, particularly like with some of the surgical specialties that we interact with. And of course, with interventional radiology, it's every surgical specialty that we will interact with. And, having an understanding of what it is that they're doing, some idea, spending time in the operating room, I think is really outstanding advice. I know I did a lot of that throughout my training, and it helped me tremendously, to see and understand, from a surgical perspective, what's relevant, what's the anatomy they're looking at, what things should I be keeping in mind. And I think it also helped me be better at radiology. For example, with watching during my neurointerventional fellowship, going to the OR and spending a lot of time watching clipping cases, really helped me better understand sort of the angiographic anatomy, because I think there are differences in the sense of how you look at things for potential endovascular treatment versus surgical treatment. And I'll never, of course, clip an aneurysm, but I want to be able to better understand, what are some of the features that perhaps make that aneurysm more amenable or a better candidate for clipping versus, an endovascular treatment. So that was tremendously helpful. So I think that's a good piece of advice.
Well, I think one of the challenges nowadays is really to work and reach out and get to know the other specialists. I'm old enough that when I went to my radiology training, I had to hang the bone board and then take the films down between readouts. That was, before PACS. And the benefit of that time period was that we had all the films. So everybody had to come down and talk to us. And unfortunately, I saw PACS, how it disrupted those conferences or impromptu discussions that you had at the readout, at the reading board, don't happen anymore. They may happen if your hospital is a multidisciplinary conference, such as tumor board or the trauma board, where you get all the different specialties in together to talk about stuff, but that's on a monthly basis. And it's not on what used to happen on the day-to-day basis. And I think really reaching out and establishing those relationships with your other specialists is really important, because then you see where you can help them. They appreciate what you as an interventionalist can do. And then it allows you to kind of really understand what's going on. So everybody's speaking the same language. Whatever area you're going to get into, whether it's interventional oncology, prostate embolization, neuro, stroke, you have to understand the lingo, so to speak. There's certain terms we use when we speak to each other, and it allows us to communicate very quickly with what's going on with the patient, what needs to be done. And you need to work really on establishing those relationships with the other specialties. And I think nowadays it's a little more challenging to do that. You actually have to reach out, because as radiologists, we don't have the benefit of everybody coming to us anymore, because we don't forward the films the way we used to. And so I think it's a challenge, but I think it's very beneficial for the practice.
Yeah, I think a really good point, that shift, technological disruption with PACS, has had, of course, a lot of advantages. I mean, look at the technologies now where we can pull up these stroke CTs and now other ones on our phones. We can, do that, make a quick decision and figure out if we're coming in at 2 a.m. But to your point, at the same time, there's more and more disconnection, unless there's an active effort otherwise, but there's more disconnection to the varying clinical specialties from the reading room. And I think that is something that certainly, interventionalists, probably not just keep in mind, but I think on a daily basis, really, make that effort to sort of go against that trend, have more of those interactions. And I think exactly to your point, establish and cultivate those relationships so that, who to call, they know who to call, whether it's review films or work on a case together, whatever it might be. I think that's, again, solid advice, especially for those in training or junior. I think that's the good way of approaching things from a, just a day-to-day practical career aspect.
I mean, it shouldn't be a surprise that an interventionalist is in the ICU. I still go out and I round and, I stand and laugh and people are like, are you lost? What are you doing up here? And it's like, no, this is kind of what we do. And, but again, that's where you meet your clinical colleagues at the bedside sometimes.
Yeah, absolutely correct. And that's what's been really thrilling to see, even being a bit removed from training, but to see that that's continued to evolve. And now with the IR residency programs, to see that really, in a sense, that's the expectation. It's no longer that it's unusual. It's really, that's the norm. That's the expectation. And, to see this certainly in the neuro and stroke space, this potential, we have some of these pilot sites, and I think things have been going well from my understanding, but, to be able to see somebody doing 6 years of IR residency and then another year of neurointerventional and spending a lot of time, on the other related clinical services and rotations, I think that's tremendous to see and will produce a lot of really, well-trained and well-rounded interventionalists.
Oh, I'm definitely excited, for the future. I've had some young med students in the, residents come to me and they're like, oh, so, what do you think the future looks like? And I think it looks very bright. I kind of have to remind myself that, we had these same discussions about 20 years ago, 25 years ago, and here we are today, and things are still moving forward. And there's a lot of neat stuff going on. The young interns, residents coming through radiology, interventional radiology specifically, bright kids. And, it's fun to work with them. They're excited about what they're doing. And I'm looking forward to what the next, decade's going to bring, because I see how much has happened just in the last couple decades. And it's just amazing.
Yeah, I agree. I look forward to, where interventional radiology will be in even just 5-10 years from now. I think it will be this well-rooted, clear clinical specialty. Others will no longer, I think, view it as the kind of quote unquote special procedures kind of service, and that was around even do parts of my training, that was around, and, kind of not just the changing of the name or the branding, but really in a real practical sense, it's just establishing that interventional radiologists are clinicians as anyone else is on the floor. We're there to help patients, help manage them. If our technologies allow us to do something minimally invasive, that's great. In some cases, we may say that, this isn't, the right option. Perhaps that patient truly should go to the operating room, but to be able to render that opinion in a consultative way, and then of course have that opinion respected from the fact of, well, this is another clinician weighing in, not just simply somebody looking to do a procedure.
Yeah, I think that's really important. During my career, I've had opportunities at certain times to collaborate with other specialties. And you need obviously the right mix of personalities to do that. But when different specialties collaborate, we do some great things, and, patients really benefit. I mean, that's in the end, what are we trying to do? We're trying to help our patients. And it's when I've collaborated with my surgical colleagues, my medicine colleagues, you have all these different viewpoints, and then you come up with a plan. And sometimes the plans are really unique because you have some new ideas and you just have some fantastic outcomes, and it's fun.
Totally agree. The collaborative approach is, it's always, I feel, more enjoyable. It's really helps to sort of reaffirm that patient-centric approach to what we all want to do. And yeah, sometimes you can come up with some really creative solutions, again, to ultimately help the patient. So that's really, I think, the best way to do it, and really, whenever possible, is what we should all strive for. Before we sort of close things out, Marty, any closing thoughts as far as interventional radiology, stroke, anything that you want to sort of pass along? Any thoughts?
Well, I always have to remind myself I stand on a lot of other people's shoulders. I was very fortunate to have some fantastic mentors and teachers throughout my career. And I still continue to meet people fortunately at the meetings, in person. And these people who are kind of legends in the field, who are so giving of their time and willing to continue my education, even though I've been doing this a long time, I'm still learning. And it's just amazing to hear from these people with even more experience than I have, because they just have so much to offer and teach. And those who are kind enough to share that, I greatly appreciate it. And, I hope to be able to continue sharing with residents, who are in training, with other junior attendings as I keep going on through my career. And because I find it very rewarding. And I think there's a lot of interesting stuff going on. I think, with the new training paradigm, with the IR residency, and now these other possibilities with alternate pathways for neuro-IR, I think it's going to be very interesting to see what the next 5-10 years bring. As I said, these young kids now who are just extremely talented go through their training and become young attendings. It's going to be really exciting, I think.
Very well put. We stand on the shoulders of giants, those who came before us, everything that they've done for the field to help train, mentor, ongoing mentorship, I think is a really important thing. I think, something I know, like you, I take advantage of, and I think that's, certainly something that we want to help continue to perpetuate. SIR has, their mentorship program as just one example, but, a lot of different things, as we talked to in parts of the conversation today, things like teleproctoring. That's another way of getting some mentorship, some help. And so I think there are a lot of tools. I find this podcast, for example, is really a great resource, for, again, ways of finding mentorship, help, advice, a lot of really great resources that are around. So an exciting time, and, certainly I think a lot of exciting times ahead. Sort of close things out. Thank you for your time today. Thanks for coming on and having a chat with me. And I think we'll look forward to hopefully further updates in the future on this podcast.
Thank you for having me, Venu. And as always, it's been great working with you, and I look forward to working with you in the future.
Likewise.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dond,
Michael Barraza,
and Ali Behetti.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson,
Josh McWhirter,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson.
And Delaney Aguilar.
Social media and PR by Ann Dang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.